You now, okay, you can go on.
Yes, thank you. Thank you, Mr. Ashraf Selim. And first of all, I would thank you and thank all the committee, especially Dr. Mohammed Fauzi and Nancy Mansour for inviting me to this big meeting, the first International Radiology Conference, to share my experience. And the title of my presentation is "What's New in Breast Cancer Screening." Breast cancer screening allows early detection of subclinical cancer. We have two types of screening. We have organized screening and individual screening. And now we try to have a new approach based on relative risk of breast cancer occurrence. Sure, mammography is would and should be in the first line tool, but has several limitations. And now we have a new techniques which are interesting to overcome the limitations of mammography. Now I would like to show you the evolution of technology by years. As we see in the 50s, we have screening by clinical examination, and in the 60s, we have the the mammography, and in the 70s, thermography and ultrasound. In the 80s, we have ultrasound of better quality, and in the 90s, the introducing of MRI. And then in 2000, we have MRI, contrast mammography, digital tomosynthesis, and elastography. And nowadays, we have a lot of techniques which emerge like ABUS 3D ultrasound, abbreviated screening MRI, DBT, contrast enhanced mammography, a positron emission mammography, mammoscintigraphy, and artificial intelligence. And now we are talking about conventional modalities. The palpation, the daily, which should be a daily clinical practice, but it is subjective and it has a little or no sensitivity for deep and or small lesions. The mammography, as I said at first, would be at the first line assessment for breast cancer screening, but it has limitations like dense breast and radiation. The B-mode ultrasound improves the sensitivity of mammography, but it has a poor specificity and low positive predictive value for cancer and low reproducibility. If we are talking about new technologies, either alone or in addition to ultrasound mammography pair, it permits to increase the sensitivity and specificity of screening examination, which can permit to avoid the morbidity of screening for benign lesion. And the following technology or techniques are available. We had ABUS or 3D echo, elastography, breast MRI, tomosynthesis, and CSMM, and mammoscintigraphy, and at last positron emission mammography. Concerning the ABUS, automated breast ultrasound, ABUS uses high-frequency ultrasounds targeting the breast. We have a 3D volumetric images of the whole breast. It is beneficial for dense breast. It permits verification of the breast from different angles, and we have better interpretation. It is shorter than traditional ultrasound, but its the operator dependency is greatly reduced. ABUS has a place in a breast cancer screening, particularly in patients with dense breast, and it allows standardization of acquisition and independent dual reading of examination. The use of computed-assisted dissection and tissues characterization by processing ultrasound signals, and it can permit image merging with MRI and tomosynthesis. This paper talked about automatic breast ultrasound in breast cancer screening of women with dense breast. The conclusion was combining this technique with mammography improves and significantly readers to detect breast cancer. Then this new paper talking about the performance of 3D ABUS, 3D ABUS comparing to conventional ultrasound Ultrasound permit to detect architectural distortion, especially with coronal view. And combined to mammography, it improves a detection of additional breast cancer in dense breast. As we see in this example, we see 3 cases of architectural distortion not visible on mammography and held hand ultrasonography. One turned out to be an invasive lobular carcinoma, as we see on the image or in the picture. Then this example shows ABUS showing a cancer, a voluminous mass, then an additional a little node approximate to the nodal. Then the second modality is elastography. Elastography always realized as a complement to mammography. It is a characterization tool and not a detection tool. The aim of this exam is to analyze the change in tissue when an external force is applied. We have 2 types, static elastography and shear wave. The elasticity of the tissue is translated into the black and white or color map. As you see in this picture, we have a color coding. We have a malignant aspect of a tumor with a red color in the peripheral crown, which is the malignant tissue, and in the center we have a soft black center. But this technique has a false positive, which are mainly fibroadenoma and scale lesions, and false negatives, lesion within high density breast parenchyma, mucinous cancer, and cancer with inflammatory stroma, lesion under 5 millimeter, and deep lesion. This paper shows that the overall sensitivity of elastography in the diagnosing of ductal carcinoma and the specificity on the basis of the literature, it was concluded that sonoelastography has high sensitivity and specificity in diagnosing ductal carcinoma. Then this paper show also the role of this technique in the screening, not also the screening, but the diagnosis, and show that it has a highly sensitive and specific for characterizing breast lesion, and it will decrease the number of benign biopsies. Then the third technique is the digital breast tomosynthesis. The aim of this technique is to overcome the limitations of conventional mammography. And as we see, we have constructed images. The limits of mammography are constructed images, lesions masked by of normal glandular tissue superimposition, lesions seen on a single incidence, and subtle images like architectural distortion. And I would like to see that the radiation, the radiation that are emerged by DBT is the same of a standard mammography. It's a low radiation, but the problem is when we combined digital mammography to DBS, then we double the dose of radiation. Excuse me, I think, yes. What is the benefits of digital breast tomosynthesis? It can remove tissue superimposition and improve visibility of lesion. It improves the contour analysis and permit better detection of subtle or low contrast lesions and better spatial information. And it can also do stereotaxic spotting for micro and macro biopsy. What is the limits of tomosynthesis? We have the volume of the breast compared to the size of the field of view. Then a difficult location like superomedial quadrant, axillary region, and deep lesion. And we have also a very dense, not dense breast, very dense breast. Then we have absence of gland fat interference. As we see here, we have an example of 2D mammography. and the tomosynthesis, which shows a specular node and other lesion. We have those lesions are superimposed in 2D mammography. Then this paper published in 2017 concerning the role of DBT in the screening, and it shows that it is an Italian paper that shows that studies are still needed for deeper evaluation, and it suggests to wait for more conclusive evidence. And we will see that the American school is totally different to the European, not all European schools, but here with Italian school. And in this paper, we show the role of DBT and the screening. It is a sub-analysis of overcome 99,000 women, and it shows that the tomosynthesis, which is when it's combined to synthesized mammography, not digital, but synthesized mammography, depicted 2.7 more invasive cancers. And the largest difference of invasive cancer detection was found in women with extremely dense breast. This example showed in the right a synthesized mammography, digital mammography, and in the left tomosynthesis, we have organized distortion architectural, and in the ecography, a mass with distortion architectural, which about malignancy. Then the fourth exam is breast MRI. As we know that MRI is very sensitive technique, and it has about 97% sensitivity for invasive cancer and 90% for in situ cancer. The specificity is variable from 81 to 95% compared to mammography, which is from 93 to 98. And it has all his interest in screening in high-risk women. And as we see in this paper, more than 50% of cancer detected on breast MRI in very high-risk patients are only detected on MRI. And here we have recommendations for breast MRI screening as an adjunct to mammography. I will not read this because I will talk about that in the end of the presentation. Here we have an example of MRI screening in 37 years old high-risk patient. At 1 year interval, the MRI show a non-mass ductal enhancement, and the biopsy yield to invasive ductal carcinoma. And now the fifth modality is the abbreviated screening MRI. What is abbreviated screening MRI? It's, as we know, that in the American experience, even if MRI is indicated in high-risk women, only 15% of women tolerate MRI because of the long time and the claustrophobia and the cost of the exam. Then in 2014, this technique, abbreviated screening MRI, was introduced by Cal, and it is advantageous over mammography because it is more sensitive for detecting breast cancer. It requires no breast radiation and no breast compression, and it's not limited by dense breast tissue, which affects almost half the female screening population and can mask abnormalities on mammograph. On the right side of my picture, you can see that abbreviated screening MRI compared to standard MRI, it contains only two sequences. We have axial T2 weighted with FS, and axial pre-contrast T1 weighted, and axial post-contrast TA weighted, and with or without DWE diffusion sequence, and with maximum intensity projection. Then if you compare the two modalities concerning the time, the abbreviated sequence takes only 10 minutes, between 10 to 15 minutes, and the standard MRI takes between 30 to 40 minutes. Then this paper shows that the abbreviated protocol may be efficient in the breast cancer screening of dense breast tissue. The fast and MIP images combined with DWE, the diffusion of MRI, are helpful to improve the specificity of breast cancer detection. We have this example of 40-year-old woman with dense breast tissue, and you see, as you see at the fast images, we have a node with a largest enhancement of the contrast compared to the MIP, maximum intensity projection. We show the mass with contours which was classified at the fast PAARS tree, and in which combined to MIP and to DWE, it was classified PAARS 4, and biopsy yielded to invasive ductal carcinoma. And this paper also talks about this technique, the abbreviated MRI, and showed the comparable sensitivity to full protocol and higher specificity. And now we're talking about the sixth exam, which is a contrast-enhanced mammography, which combines low-energy 2D mammography with post-contrast acquisition. And assessment, it is and showed the assessment of neovascularization, but is rarely used at present and have no proven value in screening. Then we have also another exam. Excuse me, it's we are talking about contrast-enhanced mammography versus contrast-enhanced breast MRI. This study, or this paper, showed that abnormal findings detected at conventional imaging, contrast-enhanced MRI had higher sensitivity for breast cancer than contrast-enhanced mammography.
Dr. Hicham, your time is out. You still have more, or you can finish now, or what?
Yes, just give me 1 minute, and I will conclude,
okay,
if possible.
Okay,
if possible.
1 minute, yes, okay.
Thank you so much. And now we're talking about positron emission mammography. It has no indication in the screening test. Then at last we will see which indication for which population. The Journal of the American College of Radiology talks about the indication of the imagery screening according to general population risk. When we have the average risk, usually mammography and digital breast tomosynthesis screening was appropriate. For population with intermediate risk between 15 and 20%, usually mammography and DBS are appropriate, and maybe MRI with or without, and ultrasonography with should may appropriate. For high-risk population under over 20%, mammography and DBS are usually, and MRI breast without and with with contrast are usually appropriate, and ultrasonography may be appropriate. And for conclusion, I am posing the question: it is necessary to remain classical, or it is interesting to include ABUS and DBT in patients with dense breast tissue in the organized screening, and also introducing the abbreviated protocol MRI in the individual screening. Thank you so much, and excuse me to be late.
Thank you, Dr. Hicham, for your presentation on the different breast imaging modalities. Thank you very much. Now we'll open the session. 5 minutes questions. We'll start with Dr. Nuran Hussain. Any questions to Dr. Nuran Hussain? Okay, no questions? Okay, we'll move on to our next Dr. Laila Abu Tahoun. Any questions to Dr. Laila Abu Tahoun? Okay, Dr. Laila, I have one question for you. Can you have a mic for Dr. Laila, please? Dr. Laila, you spoke on the rapid increase in the number of breast cancer when you started the screening. It's not exponential with the natural occurrence elsewhere. Why do you think there is a jump in the number of breast cancer in Jordan?
Yes, thank you. Actually, I think there's one important factor contributing for this is the registration. The registry itself, it was not really effective at the beginning. So now we are documenting it more. And I think also more people are reporting it and registering it. Definitely there's an increase in the number of cases, but it's not as it's really shown in the figure. I think the improved registration is the most computing factor.
Okay, thank you. Now questions to Dr. Safa Khalil. Any questions to Dr. Safa Khalil? Okay, I have one question, Dr. Safa. Mic to Dr. Safa, please. You talked about in screening, usually we do recall and we don't really put BI-RADS classification on the screening, and then unless we do diagnostic imaging. You adopted this in Emirates?
No. We only cancel BI-RAD 3. Yeah, so
yes,
we have BI-RAD 1, 2, 4, 5 normal. So only 3. Just.
But why not sticking to the recall? Just recall or no?
Yes,
that's what you did.
Yes, that's what I said. We cancel BI-RAD 3 just to either say benign or recall.
Okay, good. And the second question is that the rapid drop of the recall rate from 35% to 7%.
Yeah.
This is a huge.
It's along 7
difference.
years.
Yeah.
7 years
so
of work.
How did you achieve this?
Training and further training and training and training to the radiologists. We added the AI also, which helped the less experienced radiologists.
Yeah,
and we learn from our mistakes, definitely.
Yeah, and I will also add that the more you do the screening,
yes.
the recall rate will definitely go down,
yes.
because you have prior studies to compare with, right?
We make also monthly meetings to discuss challenging cases between the whole team. This increased the learning curve for everyone.
Okay, thank you.
Welcome.
And now questions to Dr. Tollner from Germany. Is he still with us online?
Yes.
Okay, any questions? And okay, you mentioned that you have 94 screening units in Germany and 375 mammography units, meaning an average of 4 per screening unit. Am I correct?
Yes.
And yes, and the number of the radiologists are, if I can recall, approximately 2,100.
Radiographers. The
radiographers.
600.
602. Yes, 602, and. These are double-blind radiologists, right?
Yes, double-blind reading, yes.
Okay, good. Okay, yes. Thank you. Any questions for Dr. Tollner? Okay. Dr. Hicham, Jalal, any questions? No questions? Okay. So thank you all very much, and with this we'll end the session, and now we'll call for, please stay in for a GE symposium just for 15 minutes, and then we'll finish the session. Thank you all. Thank you very much. GE